complication of the peptic ulcer. Now, I've already told you these three complications which I am going to talk now, okay, one after other, are the bleeding, another is perforation, and third is gastric outlet obstruction. Any of these topics can be asked individually in the exam. So let's focus here now. Complications of peptic ulcer. So first is bleeding peptic ulcer. See there? It is the same slide which we have talked before also. This is the most common type of complication of peptic ulcer. Among all these three which I have just stated, it is the most common one. In duodenal ulcer, the posterior surface erosion leads to massive bleeding by eroding the gastroduodenal artery. And this gastroduodenal artery is a relatively bigger type of artery there, okay? It is coming from the, celiac trunk. Okay, some other, not directly from the celiac trunk, but ultimately it is, mainly from the celiac trunk. Celiac trunk is giving different branches there, remember, okay? Now, upper gastrointestinal bleeding can manifest as hematemesis or melena. So, hematemesis means vomiting of frank blood or altered type of blood, and melena is passing up altered or black colored tarry stool from the rectum. We can see here, for example, this is ulcer, and at the base of the ulcer, there may be a blood vessel. So because of this, the erosion of the blood vessel can happen, which leads to bleeding. Now, what are the clinical features of bleeding peptic ulcer? In the history, ask the patient about ingestion of analgesics or NSAID. This is one of the very important precipitating factor for bleeding from the peptic ulcer. Now, patient is already having peptic ulcer disease. On top of that, they may be having pain because of some other reason, pain somewhere in the body, like headache, like renal colic, for example, some of the fracture, some sprain maybe, any type of pain, and they took NSAID. Now, because of the effect of the NSAID on the ulcer, they may start to bleed. Now, signs of an upper GI bleed include tachycardia. This is the earliest sign of bleeding or hemorrhage. Every student know by now, tachycardia. So nicely count the pulse, okay? And at the same time, feel for the volume of the pulse also. So what are the features of bleeding according to the rate and volume of the pulse? Yes?
Low volume pulse.
Low bounding pulse.
And what happens to the rate? It is always increased. It is always increased. Some of the students say bradycardia, okay? And they are very wrong here. That's why I'm asking this question. Bradycardia doesn't occur in a case of bleeding. It occurs only in a decompensated phase when heart is about to stop working, then only bradycardia occurs. So never answer like that. Always tachycardia. And after that, weak volume pulse. But decrease in blood pressure takes a long time, and it happens in a massive amount of bleeding only. So low blood pressure or hypotension, pallor, okay, or pale appearance, sweating, hematemesis, and melena on digital rectal examination, or you can see the black tarry stool, or patient would complain about that. So all of these are important symptoms and signs of upper GI bleeding. So what is the definition of hypotension or low blood pressure? What is the meaning or definition? Yes.
Systolic blood pressure below 90 and diastolic blood pressure below 60.
Okay.
60 to 90.
Now remember.
Only sir, hypertension, we only take for systolic blood pressure.
Systolic below 90.
Now remember that Okay, I already told you, so you need to, listen nicely in the class. And if the same question is asked again, please do not give this answer again. Hypotension or low blood pressure means only systolic blood pressure is considered. You don't consider diastolic blood pressure there. And systolic blood pressure should be less than 90 millimeter of mercury with sign and symptom is called hypotension or low blood pressure. Now, sometimes what the people say, their blood pressure is 110 and they behave like they are hypotensive. That is not a definition of hypotension. Okay, that is not. Yes, there may be, a bit of fall in blood pressure, but that is not the definition of hypotension. And another important point, some people may be having 90 systolic blood pressure or even 80, but they are not having any problem whatsoever. There is no, palpitation, no weakness, no dizziness, nothing. It may be normal for their body. And that is also not called hypotension. So hypotension means sign and symptoms along with decreased systolic blood pressure that is less than 90. Diastolic blood pressure is usually not considered. Now, what investigation we like to do to confirm, yes, this is a case of bleeding peptic ulcer? We do some basic blood tests first, like hemoglobin, platelet count, blood grouping, cross-matching, okay, and different types of bleeding and clotting tests also you can do if the diagnosis is in doubt. But if you strongly believe, yes, this is a case of peptic ulcer, then bleeding time, clotting time may not be necessary. Now, why blood grouping and cross-matching are done here? Yes, why? What is the reason?
So due to anemia, we have to transfuse the blood. Do blood grouping, cross-matching.
Very good answer. Okay, most of the students can answer this because this case is bleeding case. The patient may need blood transfusion. So we need to be ready with this. Okay, we need to be ready. At the same time, let's do some bio or chemical test also, like what is the level of urea and creatinine, just to make sure that kidneys are not suffering. This is not a case of hypovolemia. In case of hypovolemia, if kidneys decrease perfusion, then they suffer from pre-renal type of failure where blood urea nitrogen and serum creatinine will be high. Another test is an endoscopic test. Endoscopy is done to identify the site of the bleeding, number one, and to know the cause. And endoscopy can also allow us to treat the case. So we all know endoscopy has got two important roles here. One is diagnostic, another is therapeutic. Diagnostic is identification of the cause and site, and therapeutic means we can inject adrenaline into a bleeding ulcer so that bleeding will be stopped. Now, what is the acute management of a bleeding case of peptic ulcer disease? This is just like managing any other bleeding case. Okay, any other type of bleeding case. This is general management. So you are quite confident to answer that now. Assess the general condition of the patient. What is the level of consciousness? What is the general situation? What is the pulse? What is the blood pressure? And what is the skin temperature? In short, take the vital signs and record them and try to bring those vitals back to the normal if they are not. Insert IV cannula or IV line, obtain blood for grouping, cross-matching, assess hemoglobin, assess urea and creatinine, assess prothrombin time, and assess serum electrolyte. These are some of the important tests. Now, prothrombin time is not done in all type of people. It is done only if you suspect coagulopathy is the cause. Okay, this is important point to remember. Give oxygen, because this is a case of hypovolemia, to give oxygen and attach the patient to ECG machine or ECG monitor. Transfuse if systolic blood pressure is consistently below 100 and patient is constantly bleeding. Then only you give the transfusion. Otherwise, this is not a real definition of hypotension, isn't it? The blood pressure has not fallen less than 90. But here, a patient is persistently having tachycardia. That means there is ongoing bleeding and We don't wait for the blood pressure to fall so low. Give blood as soon as possible via a second IV cannula and aim for hemoglobin around 12 grams per deciliter. So that is the objective for transfusion. And probably from the other cannula, you are continuing the IV fluid. Let's move on. Now monitor urine output. This is very, very important one, because we should know the renal perfusion status. And if urine output is good, that means we are quite happy about the kidney function. Okay, and that is done by putting a catheter there if a patient is very sick. Patients is kept nil by mouth until endoscopy. Don't allow anything to eat. This is nil per oral or nil by mouth until endoscopy. Otherwise, food in the stomach may hamper the endoscopic exam. Intravenous omeprazole is given to decrease the bleeding rate. Omeprazole is a type of PPI, or in the place of omeprazole, you can give other type of PPI also, okay? Like pantoprazole, esomeprazole, rabeprazole, things like that. So dose is not important here. You will know this later on, and it reduces rebleeding rate and the need for surgery. So PPI is an important drug here. And endoscope also identify the source of bleeding, from where it is occurring. Is it from the duodenum, that is first part of the duodenum, or is it from the stomach? Now, let's move on. Let's see there. So what is the specific management now? Those are the general management we're talking about. So what are the specific treatment or management? Now, bleeding often stops spontaneously, even if you do not do anything. Means only by the general management. Anything means you just don't stay like that, you know. I mean, the only general management, like blood transfusion is given, IV fluids are given, PPI is given, patient is kept nil per oral, and things like that. But sometimes endoscopic therapy is necessary. And this is the treatment of choice. And endoscopic therapy is indicated if there is evidence of continued or recurrent bleeding from the peptic ulcer. And if there is a visible vessel in the base of the ulcer, and from that, if bleeding is coming, then we can definitely do something with the help of endoscope. And the different techniques which are available and which are done, there are injection sclerotherapy, okay, or you can give some vasopressor drug like adrenaline, both. Okay, these are not the same. Adrenaline doesn't lead to sclerosis. Okay, that is not the meaning here. Sclerosing agent can be given, or adrenaline can be given to make that blood vessel constricted. Other techniques available include heater probe and laser, just to destroy that bleeder. These are endoscopic therapy. Now, another type of management is surgery. Okay, surgery. You do definitive surgery there. And the indications are, if bleeding is persistent, okay, if bleeding is persistent and uncontrollable, even by endoscopic management or by general management, then surgery is indicated. And patient require more than 6 units of the blood needs surgery. This is a massive amount of blood transfusion. This is a heavy blood transfusion, okay? And this blood transfusion has a lot of complication. Remember that massive blood transfusion is not good for the patient. First of all, there is high chance of hypervolemia, because you have given a lot of blood volume from outside. There's a chance of infection. Second, if you give relatively a bit of colder type of blood, patient may develop hypothermia, patient may develop hypoglycemia, patient may develop thrombocytopenia. So there are lots of problems of the massive blood transfusion. So this surgery involves control of the bleeding site by underrunning or excision And a definitive procedure like a partial gastrectomy may also be necessary to save the life of the patient. Saving life is the first priority here. Okay, so if the surgeon needs to go for partial gastrectomy, it is done during that time. But in the beginning, they will try for something else like underrunning or excision or patching. Underrunning means patching of that, bleeder from that area, over shoon or something like that. So these are the different type of surgery. Now, this is the management of peptic ulcer bleeding. Now, another important types of complication of peptic ulcer is peptic ulcer perforation. And from the exam point of view, this is more important than bleeding peptic ulcer. Okay, so please pay attention here. This is a bit similar to the topic of peritonitis, which we have recently learned. Now see here, perforation of the peptic ulcer is the second most common complication of peptic ulcer after bleeding. So second most common complication after the bleeding. See here. If a peptic ulcer erodes the wall of the stomach or duodenum at a point where it is covered by visceral peritoneum only, the lumen of the gut becomes connected to the peritoneal cavity, and subsequent escape of gastric or alkaline bile can occur into the peritoneal cavity from our GI tract, and this is the complication of perforation of peptic ulcer. So let me clarify this again. Perforation means through and through opening formation, So ulcer is going deeper and deeper. It is already eroding all of the wall. Only the visceral peritoneum is remaining, and that visceral peritoneum, can also be eroded later on. So ultimately, what happens? The gastric acid or the alkaline bile may escape from the peritoneal cavity. It is usually gastric acid which is escaped there, because in the first part of the duodenum usually there is no bile presence. In case of reflux only, the bile may be present there. Regarding the epidemiology of perforation of the peptic ulcer, it occurs in men more than the women, and it has its highest incidence in the 40s to 60-year age group. NSAID or steroid treatment in patient causes acute perforation of peptic ulcer. That's why a good history has to be taken after you do resuscitation of the patient. Resuscitation is always more important than history taking. Okay, try to make the patient stable, then you have time to ask question. Otherwise, you don't spend that valuable time in asking question and don't do anything. That is a very wrong type of management. Perforation of duodenal ulcer, usually anterior wall, are 3 times more common than gastric ulcer perforation. So duodenal perforation are more common than the gastric one. Now, what is the pathophysiology? What is happening there after the perforation? So perforation of gastric or duodenal ulcer causes subsequent escape of gastric acid or even alkaline bile into the peritoneal cavity. Now, please remember, we have talked about this before also. These are highly irritant substances. They burn whatever comes in contact with them. So in the beginning, they lead to chemical type of peritonitis. Okay, so in the first 24 hours or so, the patient develops chemical peritonitis, and patient doesn't show any sign of generalized toxicity. General toxicity is seen only in severe type of infection. After this 24-hour period, secondary bacterial infection occurs there in the peritoneal cavity, and then patient develops sepsis, septicemia, septic shock, and then the generalized toxicity feature will appear. A patient looks very sick at this time. So first chemical peritonitis, followed by bacterial peritonitis. Now, After understanding these, pathophysiological mechanism, it's very easy for you to know what are the clinical features now. So let's take the history in this case. What are the questions we asked in the history? The majority of patients give a history of indigestion or epigastric pain, typical of a duodenal or gastric ulcer. So this is a long-term problem from the patient side. They give this history. And many of the time, they are already diagnosed case of peptic ulcer disease. This history is important only when they present for the first time with perforation, because we have not seen that case before. They have not gone to any places before. Then this history is important. Otherwise, if they are already a diagnosed case of peptic ulcer, no need to ask the question like that. Inquire whether the patient has taken any steroids or NSAID, because both of these drugs can cause acute ulceration, as well as they can exacerbate old ulcer to the point of perforation. Now, this is important question. Even when they come for the first time with peptic ulcer perforation, or if they are a non or diagnosed case of peptic ulcer and they come to the hospital with perforation, in both situations, we need to ask this question because they are very, very important precipitating factor. Now, ask about some other symptoms, about the severe, constant, and sudden onset epigastric pain. Severe, constant, and sudden onset epigastric pain. These are the very important feature of peptic ulcer perforation. And if the sometimes the patient may have vomiting of the blood if it is associated with bleeding as well. Okay, hematomesis may occur, but this is not a universal finding. Now, what are the signs when you examine as a doctor? What are the physical examination finding or the signs? So let's start with general examination of the patient. Patient looks quite ill, and patient lies unusually still on the bed. Patient doesn't move even an inch on the bed. And this is a very important feature of peritonitis. Movement will increase the pain, so patient doesn't move. Tachycardia is a very early feature. Shallow type of respiration, and patient may present with features of shock, means other features of shock. Remember, you can list a lot of the features. Now, what are those? What are the features of shock you can see in the patient here? Yes. What type of shock presents here first? What type of shock is this?
Sir, firstly, sir, there will be a septic shock. So, septic shock, like, sir, we have the vasodilation, we have the tachycardia. But, sir, further, when the septic shock converts into hypovolemic shock because of the increased capillary permeability, sir, then we will have vasoconstriction, etc., and the other features.
Okay. Sir, due to the bleeding, maybe the hypovolemic shock there.
Okay, good. Anybody else? Anybody else? I'm listening. Yes. Now, you're right. Both of you, okay, and other students are also trying to answer. I'm sure all of you have got concept. In the beginning, this is a chemical type of peritonitis, but in no time, chemical peritonitis may be complicated into bacterial peritonitis. And this is a feature of sepsis. And septic shock is the most important shock which occurs here. And you know the features of septic shock. There are warm peripheries. There may be fever. Okay. Then there may be bounding type of pulse, because septic shock is associated with bounding pulse. All other features of decreased peripheral perfusion may be there. For example, patient may be drowsy because of decreased cerebral perfusion. Patient may be having decreased urine output because of decreased kidney perfusion. So these are the important points you can highlight. Okay. And later on, sometimes it is complicated with bleeding as well. And if bleeding occurs along with sepsis, then some more features of hypovolemic shock may coexist there. But in the beginning, it is mainly the septic shock. Now, the important point, when you are doing the abdominal exam, what are the physical findings you get there? You see there? During inspection of the abdomen is flat and it doesn't fall and rise with respiration. This is a very important point because the muscle is contracted there, okay? And patient will not move even an inch of the entire abdominal wall. This is a voluntary type of contraction as well as involuntary. Both things are going on there. Voluntary means patient is controlling on their side, and involuntary means because the underlying inflammation, remember, the overlying muscles are contracting. So both things are there. Palpation will tell us the entire abdominal wall is very tender. There is an intense guarding and there is board-like rigidity. This term is very important for peritonitis. Please remember this. Board-like rigidity is a hallmark of peritonitis. Generalized type of peritonitis, which is important here. If we do percussion, okay, if air has escaped into the peritoneal cavity, then the liver dullness may be absent. But practically, percussion is difficult to do here because the whole entire abdominal wall is very tender. And percussion will further aggravate the tenderness. Okay, so patient may not like it, may not like that type of examination. But if we do it, because of the leakage of the air, remember where that air will go now? After the leakage of the air, where the air will go? Yes?
So below the diaphragm.
Exactly, exactly. Below the dome of the diaphragm on both sides, on the right side as well as on the left side. Okay, on the right side, it lies in between the dome of the diaphragm and the upper margin of the liver. So it may push the liver a bit downwards. So the liver dullness may be absent because of that air present there, or it may be pushed down. That is important physical finding if you can do it, but practically it is difficult to do. And auscultation, okay, auscultation is another finding examination we do. And in this case, bowel sounds are absent if this is a established case of peritonitis, and it takes time for this peritonitis to occur. That's why it is written like that. Bowel sound do not disappear until 6 to 12 hours after the onset of pain. But after a peritonitis is established, bowel sounds are absent because peritonitis can lead to paralytic ileus. There is no peristaltic movement of the bowel, so bowel sounds are absent. Let's move on. Now, what are the differential diagnoses, okay, of this perforated peptic ulcer disease? What are the other conditions you may think? If the history is very typical, okay, it is easier for us to diagnose. But sometimes what happens? Patient comes in the with the picture of peritonitis. There's no real time to ask the question. And during that time, we may think about so many other causes which may lead to peritonitis. Okay, these are called differential diagnosis. So the three principal conditions in the differential diagnosis of a suspected perforated peptic ulcer are acute pancreatitis, acute cholecystitis, and perforated viscous other than duodenum and stomach, like diverticula, which may develop in the colon. And you have already gone through that topic. One of the complications of colonic diverticula is rupture or perforation. And this is very common in older population. And it is highly associated with constipation. Now, what investigation you like to do to confirm the diagnosis? See here, the investigation are directed at discriminating the differential diagnosis and preparing the patient for possible surgery. Now, there are different types of investigation, some of the textbook, commonly mentioned like that. For example, investigations are done to confirm the diagnosis. That is the first thing. Investigations are also done to rule out the differential diagnosis. Second, and investigations are also done so that we know whether this patient is fit for surgery or not. Can I do surgery in this patient or not? certain investigations are done for that purpose also. For example, hemoglobin. If patient is very anemic, we don't do surgery in that patient. We give blood first. We bring the hemoglobin back to the 10 gram per deciliter, then only take the patient for surgery. Okay. Now, what are those investigations? One is X-ray chest. X-ray chest in the erect posture. This is standing view or erect posture, shows gas under the diaphragm. This is known as pneumoperitoneum. And we can easily see this by X-ray of the chest. But remember, both dome of the diaphragm should be included here. X-ray abdomen in erect posture can also be done. It's the same thing, But if you do X-ray abdomen, domes of the diaphragm must be included in that X-ray. Then only you can see there properly. Now, let's see how that X-ray looks. Okay. Now, see here. All of you, please look here carefully. Look at this arrowed area. See here. You can see a black shadow, a rim-like shadow here, isn't it? On the right side as well as on the left side. And we can see a small white strip above that black shadow. This white strip is diaphragm, the dome of the diaphragm. This is right dome of the diaphragm. Here is the left. And this is clear-cut air collection here. On top of those clinical features, if I see this X-ray, then the diagnosis is confirmed in 100% of the time. No other investigations are necessary for the confirmation. But still, we like to do certain other tests. Okay, and the reason we have already explained. Now, on the left, sometimes because of the fundic air shadow, it is a little bit difficult to note it. But on the right, it is quite obvious, okay, most of the time. Now, the second group of investigation which we like to do are serum amylase and ultrasound of the abdomen. Now, why? To rule out differential diagnosis like acute pancreatitis and acute cholecystitis. Third is for the surgical fitness, whether the patient is fit for surgery or not. And a certain investigations are done like CBC, urine analysis, liver function test, even renal function test, blood grouping and cross-matching, along with ECG. ECG has to be done to rule out the cardiovascular pathology. And apart from these tests, they're absolutely necessary. So the surgeon wants to know about these tests before he opens the abdomen. Remember, gastroscopy is relatively contraindicated in a case of perforated peptic ulcer because the stomach is inflated during gastroscopy. Inflated means some of the air is pushed into the stomach, and the air along with the gastric contents will be propelled or pushed into the peritoneal cavity when this procedure is done. So you really do not need to do this. Because of the typical signs and symptoms, you have already confirmed this is a case of perforated viscous. So next thing is you take the patient to the operation room and open it. And during that time, you see where is the perforation. Now, what is the management now? Okay. This is the last, discussion. What is the management? It includes some of the general management. First, patient is made nil by mouth or patient is kept nil per oral, nothing by mouth. Continuous nasogastric suction. Give good type of analgesia, very painful condition. So proper analgesia is given like iamethidine. Anti-emetic drugs are given like iamchlorperazine. Okay, this is a type of anti-emetic drug. And then IV fluid and even catheterizations are done. IV fluid, remember, this is a case of shock. So good amount of IV fluid is given to the patient. And catheterization is done to know how much urine output is there, or how kidneys are functioning. So these all are different types of general management. Now, what is the surgical management? Okay, this is the definitive management, isn't it? Definitive management. It depends on the site of the perforation and condition of the patient. Now, if the condition of the patient is stable, patient is resuscitated well, then we can take the patient for surgery, and the surgeon will open the abdomen. Okay, that is called conventional laparotomy, or surgeon can also do laparoscopic approach. But laparotomy is preferred. Okay, why laparotomy is preferred? Because all those things which have escaped into the peritoneal cavity has to be irrigated and flushed out, and that is difficult to do by laparoscopic approach. Yes, the patching can be done by laparoscopy, but all those irrigation and things like that are well done by laparotomy. Now see there, after definitive surgery and before the wound closure, the abdominal cavity should be irrigated with several liters of the saline. And this mechanism I've already explained before. Same type of thing we do in appendicular perforation also. Because pus is there in the peritoneal cavity, we need to wash that out. We need to, irrigate that thing out. And here also, some of the food particles leak outside probably in the peritoneal cavity. Maybe some acid is there. Maybe sometimes even bile may be there. So it has to be thoroughly irrigated and aspirated. And it may need several liters of saline. And this saline should be warm type of saline, okay? Not very cold. Otherwise, patient may develop hypothermia during the procedure. And what type of definitive surgery now? It depends. If the duodenal ulcer is perforated, then patching is done with greater omentum. So that is the important type of surgical therapy here. Now see this. If duodenal ulcer is perforated, simple patch closure is done. It is simple patch closure, okay? And patch closure with highly selective vagotomy should be done in case of relatively stable cases. Now, let me explain what do you mean by this. Unstable cases mean they are very sick patient. The vital signs are still not properly stable. And I cannot give a lot of time or cannot take a lot of time during surgery. Patient may collapse. So quick type of patching should be done. And in other type of stable patients, I can do some definitive other types of surgery like highly selective vagotomy so that in the future, the recurrence of peptic ulcer will not occur. Okay, this is the point. Billroth 2 partial gastrectomy can be done when perforation and bleeding occur simultaneously together. And this is the option or another option we have. Now see there, look at this picture. This is an exploratory laparotomy, which is done in the patient, and that revealed a perforated, ulcer there. Okay, perforated ulcer. Now, where is the ulcer here? It's clearly shown. This D is duodenum, S is stomach, and this ulcer is present right here. See, this is a thickened border. What do you mean by this thickened border? Anyone? What is the meaning? Yes. If I see this type of thickened border, what does that mean? What does that signify?
Like, sir, more than 1/3 of it, like, sir, more than 1/3 of that thickness is occupied, sir, by hyper.
This thickening means this is a scar. Okay, this is a fibrosis. So this ulcer is a chronic one. You got it? This ulcer is a chronic one. In case of acute ulceration, you don't see this type of thickening or this type of scar or thickened type of appearance. So simply meaning this is a long-standing case of peptic ulceration. Probably this patient has taken some exacerbating factors like NSAID or a steroid or something like that, and then it has perforated. Now the surgeon will patch it with greater momentum and seal it. Along with that, irrigation of the peritoneal cavity has to be done. So this is the treatment of perforated peptic ulcer, in this case duodenal ulcer. Now, in case of gastric ulcer perforation, what is the treatment? Now see there, for gastric ulcer, we need to go for partial gastrectomy. Partial gastrectomy. In the stable patient, without multiple operative risk factor, perforated gastric ulcers are best treated by partial gastrectomy. But let me remind you again, if the patient is relatively unstable, high-risk patient, old patient whose vital signs are not stable, or even the patient who is very sick, who come late to the hospital, a frank septic shock is already developed. We cannot, spend a lot of time with the patient in the operation room. So during that time, a patch closure with biopsy can be done, or local excision and closure and biopsy should be done, or truncal vagotomy and drainage are the alternative operation in the unstable or high-risk patient. So these are the different types of surgery. Any one of them can be done. It depends on the surgeon what they think. All the specimens should be sent for histopathological examination due to its tendency in 1/3 of the cases to be malignant. Any surgery you do in the stomach, especially in case of gastric ulcer, we should send that specimen to the histopathological examination because there is a chance of malignancy. But is it necessary to send the same thing for the duodenal ulcer? Yes. Should I send the same thing for the duodenal ulcer or not? For example, histopathology, is it necessary?
Sir. No, sir. No, sir.
No, sir.
No,
No, sir, it's only.
no, sir. We already know duodenal ulcer is always benign.
Absolutely.
Yes, sir.
Absolutely. Very good. Very good answer. It is not necessary for the duodenal ulcer because it never converts into malignancy. It is always a benign type of ulcer. Okay. Now see that this is the last picture for today. We have always completed this topic. This is the laparotomy, which is revealing a perforated gastric ulcer. Now the surgeon is showing this gastric ulcer here, right on the surface. This is the one. And this also behaves in the same way like perforated duodenal ulcer. So the management is almost similar. In the beginning, we start with the general management. Okay, then we'll go for the specific management. So with this, let me stop here today.